All right, let's jump right into this explainer. If you're a radiation oncology resident, you know this scenario all too well. Today, we're unpacking a really fascinating retrospective study by Dibbs and colleagues published in Frontiers in Oncology. It tackles a massive headache we face in the clinic. What exactly are we supposed to do when metastatic disease completely wraps around the spinal cord? Balancing durable local control with strict cord tolerance in these circumferential cases is honestly one of the toughest tightrope walks in palliative radiotherapy.
To really anchor why this matters, take a look at this clinical case straight from the study. On the T2-weighted MRI, you can see some severe spinal canal narrowing. The disease is just everywhere. It's in the vertebral body, the right lateral compartment, the posterior compartment. It's essentially a massive tumor burden directly threatening the cord. But look at what happens just 4 months post-treatment with circumferential SBRT. We see extensive regression of that epidural disease. This right here perfectly sets the stakes for our discussion today. We are literally talking about preserving a patient's ability to walk.
So here is the million-dollar question that every single treatment planner loses sleep over. How do we achieve durable local control for circumferential epidural disease without absolutely frying the cord? Can we actually deliver a curative intent, ablative dose completely wrapped around the most radiosensitive critical neural structure in the entire body? And, more importantly, can we do it safely?
Here's our roadmap for today. We're going to breeze through the circumferential dilemma, dive into the dosimetry, look at the actual efficacy, highlight the predictors of local failure, and wrap up with the safety profile. Let's get to it.
Section 1. The Circumferential Dilemma. Why is this becoming such a pressing issue for us?
Well, as systemic therapies keep getting better, our metastatic patients are thankfully living much longer. But because of that, complex spine mets are popping up way more often in our consults, and we're usually stuck between a rock and a hard place. On one hand, you have conventional external beam RT. It's the old reliable, safe for the cord. But the biologically effective dose, the BED, is just too low. That's a huge problem for radio-resistant tumors like renal cell, sarcoma, or melanoma, which actually made up a big chunk of this study's cohort. On the flip side, standard spine SBRT gives us that high BED we crave for local control. But if you apply it circumferentially, you're traditionally looking at massive red flags for radiation-induced myelopathy or bone fractures. We desperately needed a middle ground.
Which brings us to Section 2, dosimetry and treatment delivery. Can we actually pull off treating all 6 compartments safely?
Let's look under the hood at how the team at Ohio State University planned these treatments across 58 patients. The most common regimen they went with was 27 gray in 3 fractions. If you use an alpha/beta ratio of 10 for the tumor, that gives you a median prescribed BED of 51.3 gray. Now watch the cord constraints closely. Using an alpha/beta of 2, the median spinal cord max point dose BED was 59.0 gray. How did they pull that off? By using a 0 millimeter expansion from the CTV to the PTV. Let me say that again for the planners in the room. 0 millimeters. The PTV was exactly the CTV. They used a strict 2 millimeter planning risk volume around the cord, stuck rigidly to APM-TG 101 constraints, and relied heavily on a 6 degrees of freedom couch with daily cone beam CTs to ensure perfect setup.
And here's the kicker, 94%. In 94% of these cases, they successfully covered at least 95% of that PTV with 95% of the prescription dose. That is a massive win for feasibility. In fact, out of 64 courses, only 1 single patient barely exceeded the spinal cord constraints, hitting a max cord dose of 22.77 gray in a 3-fraction regimen.
All right, Section 3. The plans look amazing on a computer screen, but efficacy and local control, does it actually work in the real world?
Looking at the data, the answer is a resounding yes. Check out this Kaplan-Meier curve. We're looking at a really impressive 85% local control rate at 12 months out. And even at 18 months, it held strong at 80%. You have to remember, these aren't tiny, simple mets. These are patients with massive circumferential disease burdens, sometimes spanning 3 to 7 contiguous vertebral levels. Hitting 85% local control in this palliative setting, with a median follow-up of 15 months, is honestly fantastic, and it competes right up there with the standard non-circumferential SBRT numbers.
Now, it wasn't a total silver bullet. Out of these 64 treatment courses, there were 8 local failure events. And the pattern of where they failed is super important for us to note. Out of those 8 recurrences, 5 of them happened directly in the epidural space. This is a crucial takeaway.
The epidural space is overwhelmingly your highest risk zone for recurrence. And that makes sense, right? Because that's exactly where we are intentionally compromising the dose to respect those tight spinal cord PRV constraints. Moving to Section 4, predictors of local failure. When you're seeing these patients in follow-up, how do you risk stratify them?
Two statistically significant predictors popped out in the multivariate analysis. First up is the status of their systemic disease at the time of SBRT. If a patient's systemic disease was stable, their one-year local control was an awesome 94%. But if their systemic disease was uncontrolled and progressing, that dropped to 62%. The second major factor is sheer tumor volume. If the PTV was 132 cc's or greater, local control dropped from 96% down to 79%. So, large tumors and progressing systemic disease? That tells you you're dealing with a much more treatment-resistant biological phenotype. You need to watch those patients like a hawk on their follow-up MRIs.
Finally, Section 5, safety and toxicity profile. We always come back to the golden rule. First, do no harm.
We absolutely have to talk about the elephant in the room with spine SBRT, the fear of irreversible neurologic damage. Well, get this, 0%. There was a 0% incidence of grade 3 or higher acute or late toxicities in this cohort. Let me be super clear. Absolutely no radiation-induced myelitis occurred. None. The most common acute issue was just some grade 1 or 2 fatigue in about a fifth of the patients. By rigidly sticking to those TG101 constraints and demanding perfect daily setup, they completely protected the cord.
But what about the bones themselves? Structural integrity is a big deal. Usually, standard spine SBRT literature shows a vertebral compression fracture rate hovering around 10 to 15%. Here, they saw a remarkably low 8% progressive VCF rate for the definitive, non-operative cases. That tells us that even when you blast all 6 compartments with high BEDs, the structural integrity of the vertebra actually holds up pretty well.
So bringing it all together, the authors really hit the nail on the head with their conclusion. They explicitly state, for patients with circumferential disease, circumferential spine SBRT is feasible and may offer excellent local control without significant toxicity. It really proves that we can extend the amazing benefits of spine SBRT to a whole subset of patients who, honestly, we used to just triage straight to conventional external beam radiation.
I'm going to leave you with this thought. As our systemic agents keep getting better and survival in the metastatic setting stretches out longer and longer, your patients are going to demand more durable local therapies. How are you going to integrate circumferential SBRT to push the limits of palliative care in your own practice? Are you going to feel confident prescribing 27 Gray in 3 fractions with literally a 0 millimeter margin? I highly recommend pulling up the full paper to check out their metal artifact reduction techniques and their specific contouring guidelines. Thanks for hanging out with me for this explainer, and I'll catch you on the next one.